Hi, everyone. Welcome. I am Cassidy Avila with the Center for Optimizing Rural Health at Texas A&M University. Thank you for joining us today. Our webinar topic today is Prevention, Privilege, and Protection, How Patient Safety Organizations Improve the Safety and Quality of Patient Care, presented by Dr. Ellen Martin. Before I introduce Dr. Martin, I would like to remind you that we are all set to mute, but we will have time at the end of the presentation for questions. So if you would like to go ahead and put a question into the chat, you may do so at any time, and I will make sure they're addressed during the Q&A. If you would like to ask a question anonymously, you may do that also. You can just select my name, Cassidy Avila, from the drop-down box in chat, and I would be happy to ask a question on your behalf. I would now like to introduce Dr. Ellen Martin. Dr. Martin is the Director of Clinical Safety Research at ARCHI. She provides leadership of patient safety activities for the A&M Rural and Community Health Institute Patient Safety Organization, a federally listed PSO with the Agency for Healthcare Research and Quality. She received her PhD in nursing from the University of Texas at Austin, MSN from Queen's University of Charlotte, specializing in health systems management, and completed her basic nursing education at Angelo State University in San Angelo, Texas. Prior to joining ARCHI, Dr. Martin was the Director of Practice at the Texas Nurses Association and Director of Clinical Practice and Regulatory Affairs at the Texas Association for Home Care and Hospice. She has extensive experience in hospitals, community mental health, home health, and hospice, and holds certifications in healthcare quality and patient safety. She is passionate about improving outcomes and preventing harm for vulnerable and underserved populations. Welcome, Dr. Martin, and thank you for being with us today. It's all yours.
Thank you so much for that kind introduction, Cassidy, and for the invitation to speak today. My passion is patient safety, and I'm so excited to share this information with you. If I can get, yeah, there we go. Our objectives today are to describe the legal privilege and protections that are afforded to members of a federally listed patient safety organization. We're going to talk about the ways that federally listed patient safety organization programs support their members to improve quality and safety. And we're going to talk about some evidence-based strategies that have been shown to prevent or mitigate patient harm. So the Patient Safety and Quality Improvement Act of 2005 was designed to strike a balance between maintaining confidentiality and legal protection for patient safety event reporting while maintaining accountability and patient rights. So a patient safety organization is an entity that's authorized by the Agency for Healthcare Research and Quality to conduct patient safety activities to improve quality and patient safety. ARCHI was first certified at our initial listing as a patient safety organization in May of 2010. So we are in our 11th year. Every 3 years, we recertify. So in May of 2022, that'll be our 12th year. So it'll be our 4th recertification. So we're excited to share our program with ARC when we undergo recertification. The patient safety organizations were established by Congress when the passage of the Patient Safety and Quality Improvement Act of 2005, and then like all laws, there were some implementing rules, and the Patient Safety Act final rule was finalized in 2008. And these rules provide legal protection to encourage safety event reporting and promote organizational learning in a safe environment. And we'll talk a little bit more about the legal protections in just a little bit. The federally listed patient safety organizations were enacted in response to the landmark Institute of Medicine report, To Err is Human. And that report talked a lot about encouraging reporting of patient safety events to improve care delivery. And patient safety organizations are the only means by which healthcare providers can review and analyze adverse events without fear of litigation or harm to professional reputation or licensure. So it encourages this reporting and broad discussion of adverse events, near misses, and then also establishes these confidentiality privileges. So a little bit of background. In 1999, the landmark Institute of Medicine report To Err Is Human started this national conversation on patient safety and reduction of harm in healthcare. And that report came about because of several patient safety events that were highly publicized in the media in the 5 to 10 years prior to this national report. There were many physician leaders, including Dr. Nancy Dickey, our executive director at ARCHI, who was at the time the incoming president and then president of the American Medical Association. And those newsworthy events were things like Boston Globe reporter Nancy Lehman was a beloved health column reporter, and she died of a 10 times overdose of chemotherapy. And there were just so many events that a national report was done. This is the report where it was first publicized that between 44,000 and 98,000 people a year die from medical errors. And if you think about that's the equivalent of a jumbo jet crashing every single day. Subsequent reports talked about medical errors causing more than 250,000 deaths a year. And before COVID-19, it was the third leading cause of death in the United States and cost about $20 billion. COVID will knock it out of third place for a while, but it'll be back up there because our problems have not been solved yet. Many patient safety events go unreported because of the fear of consequences of reporting. So one of the things that was in this landmark report was a set of recommendations. And recommendation number 6, there's a whole chapter on voluntary reporting systems. And what it said was that to facilitate participation in reporting, Congress should enact laws to protect confidentiality of certain information collected. And without such legislation, healthcare organizations and providers might be discouraged from participating in reporting systems out of worry the information they provide might ultimately be subpoenaed and used against them in lawsuits. And so that's how the Patient Safety Act and final rule came into existence. The Patient Safety Act of 2005 outlines the criteria for organizations to become a patient safety organization. It also outlines some exclusions for organizations that are not eligible to become a patient safety organization. They designate, this law and rule designates the Agency for Healthcare Research and Quality, AHRQ, to set forth requirements for the initial listing and for recertification. And some of those requirements are things like there's 8 activities that are required of patient safety organizations, and we'll talk about a couple of those. It also defined key terms that are unique to this law and rule, and we'll talk about some of those. And then it described the confidentiality privileges and protections, including some exceptions for permissible disclosure when patient safety protected information could be disclosed. So one of the first activities that's required from PSO is that the primary mission or activity of the organization that wants to become a PSO is to improve safety and quality. And that fits perfectly in with our ARCHI PSO mission. Our primary activity is to improve safety and delivery of healthcare, quality of healthcare delivery. And we do not do this independently by ourselves. We accomplish this through collaboration with our contracted provider members of our patient safety organization. Another requirement is that we have a team of qualified professionals to conduct the patient safety activities. So we have our physician leadership, Dr. Nancy Dickey, Dr. Robert Steele. Dr. Peter Yu is our Chief Information Officer, and he is our AHRQ PSO authorized official. So one of the requirements is that an authorized official is designated. And because we're going to talk about the safety net event reporting system, but a lot of the compliance law and rules is all around information security, information reporting, information analysis. And because Dr. Yu is our Chief Technology Officer, he's also our authorized official. Jetty Edelman, our Chief Operating Officer, is the primary contact for ARC. We have a medical director. I'm the director of the program, and I'm, as Cassidy mentioned in the introduction, certified in quality and safety. We've got a PSO pharmacist and a whole team of other folks who help us accomplish our PSO mission. One of the primary requirements of a PSO is that we work with provider members to promote a culture of safety. And a culture of safety has a lot of elements to it, but it's basically a culture in which staff are encouraged to report incidents, near misses, and unsafe conditions in order to accelerate organizational learning about hazards and risks. So it doesn't help to report incidents if nothing's done with that information. It's all about organizational learning in a safe, protected environment so that improvements can be made. We also supported Just Culture, and Just Culture is a system of workplace justice that's based on a philosophy of shared accountability. So it's a culture in which organizations are held accountable for the systems they design and how they respond to safety events, and how they respond to employees involved in safety events. And on the other hand, employees are held accountable for the quality of their choices and for reporting errors that they find or errors that they experience, and reporting system vulnerabilities. So if somebody is aware that things are glitchy around here for whatever reason, that is reported so that system vulnerability can be acted upon. So a Just Culture recognizes that individual practitioners should not be held accountable for system failures over which they have no control. And it also recognizes that many individual errors, or what they call in the safety science literature, active errors, represent these predictable interactions between human operators and the systems in which they work. Quality guru W. Edwards Deming used to talk about systems are designed and maintained by management, and employees work within those systems. In contrast to a culture that's a no blame culture as its governing principle, Just Culture does not tolerate conscious disregard of risk or misconduct, such as falsifying a record or performing professional duties while intoxicated. So Just Culture is also all about accountability. Another requirement of patient safety organizations is to facilitate safety event reporting. And at Archie, our clients, we work with them to use the SafetyNet patient safety event reporting system. So it's a secure, user-friendly electronic patient safety event reporting system. We can work with clients who use their own systems. So there are many patient safety event reporting systems available on the market, and we can work with them so that they can report their safety events to the patient safety organization, which is part of the protections we'll talk about in a minute. Our SafetyNet, the TSN, is based on what's called the ARC Common Formats. And what that is a standardized data set for uniform patient safety event reporting. So having a consistent set of definitions facilitates event reporting and analysis across providers and across organizations. And then also part of safety event reporting is analysis and then providing feedback to the PSO provider members that are contracted with us. So really, it's all about organizational learning. So one of the requirements for patient safety organizations is that we provide educational activities. So when a provider member first contracts with Archie, we provide patient safety organization education for onboarding on the privileges and the protections. And we'll talk a little bit about how we help set up a safety system design with our clients. We also provide education on root cause analysis. Also, we're going to talk in just a little bit about evidence-based strategies to improve quality and safety. And one of the things that is in that realm is team steps. So if you're not familiar with team steps, stay tuned till the end. We also can provide a venue called Safe Tables. And Safe Tables is an organizational learning activity or a forum where the patient safety organization provider members can meet, or you can have, we've just started with some national safe tables through the Alliance for Quality and Improvement in Patient Safety. And those are topic related on things like workplace violence, assaults against staff members, or the one that's coming up in September will be on telehealth and ensuring safety with televisits. And then we also can do education on Just Culture as well. Just Culture is really important related to patient safety event reporting, because Just Culture really is part of the organizational culture in terms of non-punitive response to errors and safety events. So if you try to report a safety event and your manager's all like, oh my gosh, what were you thinking? And why didn't you follow the policy? And why didn't you do this? If it's all blame and finger pointing, that diminishes psychological safety and people are less likely to report incidents. So in a Just Culture, it's an open culture with psychological safety to encourage event reporting. So all of this is about the organization. So how do patients benefit? And we're going to talk a little bit about the privacy privileges and protections in just a little bit. But through the Patient Safety Act, patient and family rights to access information in the medical record is preserved under this protection and privilege law. There's also a broader sharing of information among providers that facilitates organizational learning to understand and address problems that affect quality of care and safety of patients. And then as the providers address these problems more openly in a culture of safety, then risk to patients can be mitigated or eliminated. And then patients also benefit from the introduction of evidence-based strategies to improve quality and safety, because that facilitates organizational learning and change that results in safer care. So as a patient safety organization, we don't contract with our providers and then start telling them what to do. We help them with their safety system and identify what it is they'd like to work on that they've already identified as a safety opportunity, or we can help with a gap analysis of their safety system to help them identify some things that they'd like to work on and collaborate with us. Okay, so the legal privileges and protections. The privilege and protection in the Patient Safety and Quality Improvement Act protects sensitive information about patient safety events that are designated as patient safety work product. And that term, patient safety work product, is a unique term that's unique to this Patient Safety and Quality Improvement Act. So you might have heard of like attorney-client privilege or attorney work product. And this is a similar concept. So this patient safety work product, and we're going to talk a little bit more in just a minute about what is patient safety work product. But this protected sensitive information is protected from disclosure. So there's confidentiality protections for providers, and it's protected from discovery in civil, administrative, disciplinary proceedings, except where it's specifically permitted. So one example is it's okay for an organization, if they want to participate in some kind of safety science research, to share de-identified work product information. So that's one of the special permissions. And then there's special permissions for things like law enforcement, if there's been an alleged crime, that the organization can share patient safety work product. Strong privacy and confidentiality protections are intended to encourage greater participation by providers in reporting, examining, discussing, and learning from these patient safety events. So all of this privilege and protection happens in the context of a patient safety evaluation system. And if you actually go read the law or the rule, it talks a lot about a patient safety evaluation system. And what it is the processes and systems within an organization for collection, management, and reporting of patient safety information to a patient safety organization. So the patient safety evaluation system, and we call it the PSES for short, is conceptual. It's that combination of processes, policies, the people that work together as a system to improve quality of care and patient safety. So when an organization first contracts with a patient safety organization, they already have a safety system in place. So every organization already does something for patient safety. There are licensure requirements. There may be accreditation requirements. So organizations already have some kind of system in place for reporting some kind of safety event. However strong it might be, it might involve incident report forms. It might just be as simple as calling up the CEO and saying, we had a never event today. So whatever the safety system is already in place. And then we help our provider member to designate what the patient safety evaluation system is. So activities of this patient safety evaluation system are the things like collecting data to improve safety, quality, and outcomes, reviewing data and taking actions as needed to mitigate harm and improve care, analyzing data and making recommendations to continuously improve safety, quality, and outcomes. The patient safety evaluation system is part of the system that conducts root cause analysis, or maybe in your organization, you call it intensive case review or mortality review, and then the aggregate information from all those activities. The patient safety evaluation system in the Patient Safety Act and Rule talks about the PSES being the group that determines what will and won't be reported to the patient safety organization. The patient safety evaluation system reports information to the patient safety organization and receives feedback from us, from the patient safety organization, in the form of the analysis that we perform on their patient safety event information that they provided to us. So it's a two-way collaboration and communication. There's nothing in the patient safety law and rule, if you read it, that says that you have to document what the patient safety evaluation system design is. But with a lot of privilege and protection legislation, laws, and rules, there are challenges sometimes by plaintiffs' attorneys to those laws and rules. So they recommend it as a best practice to go ahead and document the design of the patient safety evaluation system. And it looks kind of like an org chart, and it's unique to every organization. And what we do is help the provider member that contracts with us to identify what's inside the patient safety evaluation system. So we basically look at what the current state is, and we have conversations and discussions as part of the onboarding process with a patient safety organization. So we look at things like, what are your safety events or the processes for your reporting now? What's the current state? What do you do with adverse events, sentinel events, never events, the incidents, near misses, and unsafe conditions? And in the ARC common formats for the safety net, ARC defines an incident as a patient safety event that reaches the patient. A near miss is a patient safety event that does not reach the patient. So those are the safety events that are caught before they reach the patient, either by luck or by vigilance of the staff that are taking care of that patient. And then unsafe conditions are anything that increases the likelihood that a patient safety event might occur. So those things might be things like hospital-acquired conditions. Root cause analysis is another example of a process for safety events. And then there's committee reports. So what committees do you have? And what are the minutes to those meetings, and how are safety events discussed and aggregated and trended? So there may be in your organization a patient safety committee or a risk management committee and those kinds of things. And then what other kind of structures are in place that support the patient safety evaluation system? So a lot of licensing rules, require a quality plan, a safety plan, and those kinds of things. And your policies and procedures all relate to this patient safety evaluation system. So in the context of this patient safety evaluation system, we said that they designate what is patient safety work product. And we work with our members to find out what kind of patient safety work product do they have. And it's defined in the law as any data, reports, records, memos, analysis, written or oral statements, or copies thereof, which could improve patient safety, healthcare quality, or healthcare outcomes. So that part is straight out of the law. And this is the three, what they call the three pathways to PSWP. So it would be information assembled by a provider for reporting to the PSO and reported to the PSO. So like using the safety net to report events to us, or developed by the PSO to conduct patient safety activities. So the things that we develop to share with our provider members, maybe a report of what safety events were provided to us, maybe could be as simple as a count of activities or a count of events, or it could be a deep dive analysis, or which constitute deliberation or analysis of patient safety information. So an organization can deliberate and analyze their own safety events within their patient safety evaluation system without reporting it to the PSO. So any kind of deliberations or analysis of the patient safety information. There are limits to what can and cannot be patient safety work product. And I love this little visual because of that idea of thinking outside the box. So the credit for this goes to Peggy Benzer, who's the executive director of the Alliance for Quality Improvement and Patient Safety. We call it AQIPS, and it's our professional organization for patient safety organizations. So patient safety organizations join AQIPS, and Peggy's the executive director. So everything in the box is protected. It's under that umbrella of protection. So if you're Joint Commission accredited, they require proactive risk assessments. Those are protected. Failure modes and effect analysis, any kind of real-time analysis of your errors, any root cause analysis that you do, dashboards, scorecards, quality meeting minutes, drug reviews, statistical analysis, mortality reviews, safety meetings, all that's protected. What's not protected is facts in the medical record. So we talked about how this Quality Improvement Act preserves the rights of patients and families so they can get information in the medical record. Also not protected is things that were not for the purposes of improving quality or safety. So those are the administrative things like billing or mandatory reports to the state. The purpose of that is to make the mandatory report to the state. So those kinds of things are not protected. Written information relied upon for treatment decisions can be things like a referral letter. So it's technically not a part of the medical record, but patients and families do have rights to access that information as well. And then providers acting below the standard of care or any kind of alleged criminal activity, not protected. And that makes sense because this Patient Safety Act was not designed for bad actors to hide behind to protect their criminal enterprise. It was to facilitate organizational learning for patient safety events. And we want to preserve that true mission of this act. So it helps because to talk about this in terms of a patient safety event life cycle, because when you think about a patient safety event, these things are all wrapped up together. The things that are protected happen, they co-occur or they happen side by side with the information in the patient's record. So if we take the example of a fall safety event, when a patient falls, what's documented in the patient record is that the patient fell. The nurse might document when they were notified or when the patient was discovered on the floor, any kind of assessments or injuries, any actions that the nurse took, who they notified, if there were any MD orders received, if the patient was sent for x-rays, all those kinds of things. And, the nurse probably, if depending on the organization's policy, would complete and submit a patient safety event or incident, some kind of incident report. And then in the organization, that patient safety event is that incident report is processed in some way. Maybe it's sent to a quality department who reviews the fall incident report. Maybe they investigate and they figure out that the patient was high risk to fall, but there was no bed alarm. Maybe the quality department aggregates the data. Maybe the safety committee analyzes and reviews that aggregate data, and maybe they trend falls with injuries, and maybe they don't look at falls that did not result in injury. The patient safety committee or whatever committee it is at the organization might discuss improvement ideas. And then they may come up with an action plan, like a fall risk assessment, implementation of bed alarms. So this is just an example of what happens with a fall event. So in the context of a patient safety organization, when that patient falls, there are things that are not protected, and we talked about the documentation in the patient record. The patients and families have a right to that information. So that part's not protected. Administrative documents, anything related to things that are for another purpose, like the maintenance logs for walkers, for example, or billing records, any of that stuff not protected. And then the action plan's not protected because you want to share that widely, what was done. So patients and families have a right to know what happened to me or my loved one, and what did the hospital do about it to keep somebody else from going through the same situation. What is protected, if you're a member of a patient safety organization, is all the incident reports, all the quality data, all the part about the investigation, the trend reports, the minutes, and all of that is protected. So if a plaintiff's attorney wants to know what was the aggregate data for falls, they can't get that because it's not subject to disclosure. And it's not, it's privileged and it's protected if the organization is a patient contracted with a patient safety organization. So this Patient Safety and Quality Improvement Act applies in both federal and state proceedings, and all the states are different and have different kinds of protections in place already. And sometimes they're limited, like there are physician peer review laws that protect physicians. There are some kind of peer review statutes that protect hospitals, but not home health agencies or hospices or nursing homes. So there's limitations. So this is a federal sovereign protection. These protections can never be waived, but the patient safety work product, that protected information can be disclosed under permissible disclosures. And we don't really have time today to go into all that excruciating legal detail of what all those disclosures are, but I'm happy to talk to somebody offline if they're interested. And then if the protections are greater for the federal law than what's available under state law, then this federal sovereign protection preempts the state law. So once again, patient safety work product, this protected information is not admissible as evidence, and it is not subject to discovery. The protections are enforced by the Health and Human Services Office of Civil Rights, and that's the same entity that also enforces the HIPAA protections for patients and families. So patient safety science, what are some of the things that we do with our clients and share some of those evidence-based strategies to prevent harm? So some of those, and this is just a short list. There is an extensive list of safety science evidence, but I just wanted to highlight a few. So there are things like standardized processes, protocols, and guidelines. So we help organizations identify if any of those exist and share those with our provider members. Checklists is a well-known safety strategy. And if you had a chance to read the Checklist Manifesto by Dr. Atul Gawande, one of the things that he talks about is deciding whether you want a read-do checklist or a do confirm checklists. And those two kinds of checklists are different. So a read do checklist is a checklist that you use for things you don't do very often. So you read the step and then you do it and check it off. And so that way you can make sure if you're not familiar with something that you can read about it and do it as you go. So it's like a recipe. And a do confirm checklist is for those kinds of things that you do routinely and you often do them from memory. And when you do a do confirm checklist, after your procedure's over, you look at the checklist and you check off, did I do this? Did I do this? Did I do this? And so that is a great improvement for patient safety. And I heard a presentation at a conference once. It was really cool. And a labor and delivery unit was talking about implementation of checklists for maternal care. And one of the things that they decided to do as part of their safety culture and engaging staff was to make it a practice that when they did the do confirm checklist when the team was in the room, they would make it a practice to say out loud, wow, I'm glad I checked, if there was ever a misstep that was caught using that checklist. And that helped reinforce the importance of using the checklist. There's a lot of information in safety science about systems approaches to quality and safety. And often we talk with our clients about strengthening the safety system. So we teach root cause analysis, and root cause analysis is the investigation of a safety event from a systems perspective to identify system vulnerabilities. And so the interventions that and the action plan that comes out of a root cause analysis is all designed to strengthen the safety system around the patients and the people working within the system. And there's a lot of information about human factors. And in this time of COVID, that's particularly relevant because human factors like fatigue, distractions, exhaustion, burnout, all of those kinds of things are human factors. Humans have fallible memories. And so not being able to, relying on your memory can be a source of error. And one of Dr. Lucian Leape, who was an early quality pioneer from Harvard, a physician from Harvard, one of his favorite quotes was reduce reliance on memory. And that's what the importance of checklists are all about. And then part of safety science too is change management. If you're going to implement just culture, for example, it's more than just educating people about just culture. You have to really evaluate what is it in your system that's going to get in the way of change. What are the barriers going to be, and how can we implement it and hardwire it and make it today's work today so that we can make sure that just culture isn't something that we just talk about, but part of the fabric of our organization. We also talk a lot about high reliability principles, and those are come from industries, high reliability industries like the nuclear industry. And some of those principles are things like preoccupation with failure, always looking to see where something might fail so that you can shore up the safety system. And then also deference to expertise, making sure that frontline staff are involved in safety improvement because they're the ones who know what the workarounds are when their safety system isn't working like it should. We already talked about root cause analysis. There's also a proactive process that's similar to root cause analysis, but you do it before there's a safety event. So it's a high risk process analysis or FMEA. So you don't have to wait for a safety event to occur. An example might be to examine the process of discharging in patients, say with neurological injuries to post-acute rehab, to make sure that when the patients get to their destination, that everything is well coordinated and in place for them for their maximum recovery at their next location of care. We also talk a lot about sharing lessons learned. It's hard to learn when people don't feel comfortable talking about what they've learned through all of this analysis. The Joint Commission talks about robust process improvement. So going beyond just doing an educational program to remind everybody to document something, but knowing that reminders are not enough, and what else can we do to help people do the right thing at the right time. And then teamwork and structured communication are very important evidence-based strategies to improve clinical care. So I'm going to talk a little bit about that in just the last little bit that we have left. So one of the big safety strategies was developed by the Department of Defense, and it's called Team Strategies and Tools to Enhance Performance and Patient Safety, or TEAM Steps for short. And I hope many of you have heard of TEAM Steps. There are domains of, it teaches specific skills around communication, leadership, situational monitoring, and mutual support to improve knowledge, attitudes, and performance of the care team. And there are decades of research and evidence from high-risk fields showing how TEAM Steps works, including the Department of Defense. I have a brother-in-law who's actually a Navy seaman who served on a nuclear submarine for several years. And it was cool to talk to him because they really do use the SBAR communication model. And we'll talk about SBAR in just a minute. But this TEAM Steps provides specific tools and strategies for improving communication and teamwork, reducing the chance of error, and enhancing patient safety. The outcomes of high-performing teams are adaptability, accuracy, productivity, efficiency, and safety. And those are the official outcomes. But as a person who works at a TEAM Steps organization, I can tell you that having a high-performing team to work with is so rewarding. So there's a whole piece of joy in work and knowing, a comfort in knowing that if I get overwhelmed with something, that I've got mutual support, that there are people that I can count on, and we have a shared mental model because we all learn TEAM Steps together, and we know these different principles and strategies. Communication is vital. The Joint Commission data continues to demonstrate the importance of communication and patient safety. So the Joint Commission collects sentinel event information. And in the 10 years between 1995 and 2005, ineffective communication was identified as a root cause in nearly 66%, 2/3 of sentinel events. And between 2010 and 2013, communication was in the top 3 root causes of the sentinel events that are reported. So often it's something simple. Somebody forgot to tell somebody something, or maybe somebody was told, but it wasn't effective in terms of the urgency or following up on the communication information. And that's where these TEAM Steps skills come in so handy. So some of the communication strategies are all around assertive communication. So maybe questioning a doctor's order, for example, you can say, I need some clarity because here I've got this, I've got a surgical consent that says that we're operating on the right side, but this patient actually has right-sided weakness. So isn't the brain bleed on the left side, maybe, if the patient has right-sided weakness? So I just need some clarity. Or you can share what they call cuss words. And it's almost like a principle of stopping the line and just saying, hold up, I have a concern, I'm uncomfortable, I fear that safety is at risk. And when you say that, and you're in an organization that does TEAM Steps, when people hear I have a concern, their risk monitor goes up and their risk monitor fires. And then everybody can stop and say, wait, well, what is your concern? And then you can have a respectful, collegial conversation that could prevent an event. When people fear speaking up and they know something is wrong, that can lead to tragedy. Part of my job at the Texas Nurses Association, was before every board of nursing meeting to look through the discipline files and find out what is it that nurses are being challenged with? What kinds of things are nurses getting trouble for? And one of the common things is that a nurse might call a physician, for example, and say, you know, I'm having a concern about this fetal heart rate. And the doctor says, okay, well, just continue to monitor him. Thanks for calling me. But they have to continue to monitor and follow up. And so there's this idea of a 2 challenge rule in team steps to say, you know, I called you an hour ago and I'm still worried this is getting worse. And if you're in the middle of a code or any other kind of example, you can say it once, but if you don't feel heard, you've got this professional responsibility to say it again. And that's what the beauty of team steps is that you have a structure and words that you can use to make it easier to do those kinds of challenges, especially if you have a power differential between you and the person that you're talking to. Part of that team communication strategies and team steps is this idea of a shared mental model to make sure we're all on the same page about whatever it is that we're working on. There's also information about doing briefings, huddles, and debriefings. So a briefing might be something that you do at the start of the day before the workday begins. These are the patients we have on the unit today, and this is what's going to happen. A huddle might be when there's a significant change in condition and we get everybody together and say, y'all, we need to have a huddle. So let's figure out what we're going to do. Can you go call the family? Can you call the attending physician? And I will get the patient ready to go for an x-ray, for example. So a huddle is a great way for teamwork. And then debriefings happen after the fact, where we can talk about what went well and what do we want to make sure we keep doing and what could we have done to make it a little bit easier. Handoffs, there are communication strategies specific to handoffs, and then structured techniques like SBAR, which is situation, background, assessment, and recommendation. And that was used definitely in the military. And you can think about the advantage of it in a highly tense situation, because if you know that a soldier's coming to talk to you and you're the captain or you're the major, they're going to tell you what the situation is. They're going to give you some background and they are going to get to the recommendation. So you don't have to be impatient. You can just listen for what their assessment is and what they recommend. And so often, I worked in quality improvement in home health and hospice, and sometimes I'd hear back from our doctors and they would say things like, give us a recommendation. You know, the nurses call and say, this is the situation in the background and this is what I think. But you've got eyes on the patient. What do you recommend for that patient? And that kind of thing really helps with communication. And then, of course, readbacks is definitely a safety technique related to things like verbal telephone orders. So to read it back to make sure you got the dose right, the medication right, that you heard correctly. So those are just some examples, and I'd love to hear from you all what questions you have and what kinds of safety strategies do you already implement in your organization. And you could type into the chat or just, Cassidy, can people unmute themselves?
They should be able to. Or if someone would like to verbally ask a question, you can raise your hand if you know how to do that, or just type it into the chat, and I would be happy to unmute you if you need help with that.
Thank you so much. Have you all heard, has anybody heard of patient safety organizations before, or is this the first time?
I'm not seeing any responses in the chat, but if anyone would like to answer Ellen's question in the chat, okay, so someone said they've heard of them before. You can just drop your response into the chat. We have another yes.
Great, thank you. I know we covered that information really, really fast, and you know, it seems simple on the surface, but there's layers layers of information about this. So I'd love to have any discussion or questions you guys have. Are any of the participants on the call, do any of y'all use any of the team step strategies? Oh, that's a great question. So are all patient safety organizations federally listed, and what does that mean? So organizations can call themselves a patient safety organization if they're a consulting group or whatever, and they do patient safety activities with their clients. But not all are federally listed. So what federally listing is when you apply to Agency for Healthcare Research and Quality and you meet the criteria and they approve your application. So there's a lot of questions about your, do you even qualify as an organization? So you have to be eligible to be a patient safety organization. So one example is health plans cannot be a patient safety organization. So if you're a health plan, you're not allowed to do that. And then you meet the criteria and they evaluate your application. And if you do indeed meet all the criteria, then they will certify you as a patient safety organization. And there's a list of the federally listed or federally certified patient safety organizations on the AHRQ website. So if you just Google AHRQ patient safety organizations, you'll get to the page where they're all listed. And I think the last time I looked, I think there was around 85 or 88, something like that. I mean, it may have increased up to the low 90s by now. Oh, and we got a great comment in the comments section, using briefings and huddles a lot. We use huddles on our team. It doesn't have to just be clinical. Sometimes we'll have a huddle in advance of a meeting and just have a quick discussion to make sure we're all on the same page about whatever we think the topic's going to be. And we can work out any misunderstandings in advance. So it doesn't have to just be clinical. Oh, and Ms. Edelman, Jetty Edelman, posted the federally listed patient safety organization website, so you can link to the website and you'll see the Archie listing. Since we're the A&M Rural Community Institute, we're up at the top of the list. 95 nationally, Jetty said. So they've added some.
And Ellen, this is Cassidy. Just from a conversation with you this morning, I now know that this week is, or maybe this Friday, World Patient Safety Day.
That's right. Thanks for reminding me of that. So the World Health Organization has a patient safety week for World Health, and they've got a website. Every year they have a theme. Last year's theme was workforce safety. Was something about workforce safety. Patient safety depends on workforce safety. This year, it's all about maternal health, and World Patient Safety Day is Friday. And so it's all about safe maternal care. And, you know, in rural health, we have challenges with maternal care. We have some disparities in the United States. So, you know, we're better off than a lot of countries in the world, but we're ranked kind of low for some disparities in maternal health care. So yeah, thanks for reminding me of that. So this Friday, you can celebrate the safety folks in your organization. It was really fun for me to come work at Archie and talk to Dr. Nancy Dickey, our executive director, about what it was like to be at the American Medical Association as the first woman president of the American Medical Association, right in the time that all of this was happening. So, you know, she's always talks about how it took a group and it took a village, but the American Medical Association chartered the National Patient Safety Foundation during those early years in the 1990s, after the Institute of Medicine came out. And she talks about how, you know, when you're the incoming president, the president, or the past president, reporters would ask, well, what are you doctors going to do about patient safety? And so that's how that National Patient Safety conversation got started in the National Patient Safety Foundation. And when I was looking up things like the congressional testimony, like I was curious, who was the author of the Patient Safety Act and what kind of hearings were held? And I ran across Dr. Dickey's name. She gave Senate testimony at a joint committee on the importance of this Patient Safety Act. So it's really cool to be able to work here now and further the work that got started all those years ago to help improve safety for our families, our loved ones, our neighbors, and ourselves when we're in need of health care as well.
I think we have a few more minutes if anyone has a question that you want to get in before we end the session. But I do want to thank you, Dr. Martin, for your excellent presentation. We're so appreciative of your time, and we know how busy you are. And Dr. Martin did agree to share her slides. So following this webinar, we will send out an email that will include a link to the CORE website, which will have this webinar recording posted, as well as a link to the slides. So you'll be able to pull that down should you want to share it or watch it again.
Thank you so much, Cassidy. And I included my email address here. I'm happy to correspond with anybody who's interested in a little bit more about patient safety. We'd love to hear from you. So thank you so much.
Absolutely. And I don't see anything else. Jetty did share a little note in the chat, but I don't see a question other than that. So I think we'll go ahead and adjourn. But thank you all so much for your time with us today. And we look forward to seeing you next month. And thanks again, Dr. Martin.
Thank you, everybody.
Bye.